No photography is permitted in the session. Thank you.
Good afternoon. I'm Cam McLeod, Chair of the Cystic Fibrosis Foundation Board of Trustees, and it is my honor to welcome each and every one of you to this year's North American CF Conference. You know, you are an amazing group. Nearly 4,000 scientists, researchers, physicians, caregivers, and other medical professionals. You've traveled here from all parts of the globe to exchange ideas, forge collaborations, and look for new ways to understand how we can work harder and faster to reach our shared goal to conquer cystic fibrosis. Thank you for taking time out of your very, very busy schedules to be here with us. The engines of progress, as you all know, don't run by themselves. Advancements in CF research and care are fueled by the support of countless volunteers and donors. I am so proud to welcome some of these very special people who join us today: CF parents, members of families, and friends of the Cystic Fibrosis Foundation in the Southeast. I'd like to ask our volunteers to please stand as we thank you and all those you represent across the country. Early this year, many of us got a big dose of excitement that the real progress of CF can bring. Did anyone else in this room happen to see the CBS News on January 31st?
This is the CBS Evening News with Scott Pelley.
There is a breakthrough tonight in the treatment of cystic fibrosis, the fatal disorder that afflicts about 30,000 Americans. The FDA today approved a drug called Kalydeco. It is the first drug that treats the genetic defect in CF, not just the symptoms. The drug works in only about 4% of patients, but it points the way to treatment for the rest. An official at the Cystic Fibrosis Foundation told us today, quote, "It's a game changer."
I don't know about you, but every time I hear that, I get cold chills, and I am filled with gratitude. We would never have reached this game-changing milestone in the fight against CF without the persistence and collaboration of so many people around the world: the scientists and researchers at Vertex, the clinicians who led these important studies, and the people with CF who participated in them. You made it happen, and I thank you. I am profoundly moved by what Kalydeco is doing for people with the G551D mutation, and I cherish their excitement and the excitement of their parents when they tell me how much their lives have changed because of this remarkable new drug. At the same time, I realize that my son Will, like many other children and adults with CF, will not be helped by Kalydeco alone. For Will and the thousands of others with different mutations of CF, the journey is going to be longer. But I stand before all of you who are so committed to helping all people with cystic fibrosis, and I am filled with hope. I know that you are here for Will and for the 70,000 people around the world who courageously fight CF every day. I know that with Kaleido, we now have a roadmap for how we can continue to target the basic defect in CF and find treatments for all people with this disease. Over the years, I've had the pleasure of sharing with you the many milestones of Will's life, going to college, graduating, now approaching his 31st birthday. And it's been interesting. In the halls after these sessions, people have said to me, "Why don't you bring a picture of Will?" So, meet Will. And then another favorite picture of him. Not a bad swing, eh? Thank you. Making it possible for Will and all people with CF to live full, healthy lives and to pursue their dreams is what we are all about. I know that we are moving in the right direction. The scientific and medical knowledge that we share this weekend will help drive the momentum that this community has created to develop new therapies and to provide the highest quality of care to CF patients throughout the world. I know that you will not stop using your talents to find a cure for CF, and I can assure you that the CF Foundation also will not rest until all people with CF, every single one of them, will never have to worry about CF again. Thank you for giving us so much hope and for helping to accelerate our search for a cure for my son and for every family affected by this terrible disease. Now I'd like to share with you another message from Scott Pelley, who, by the way, is not just an eminent reporter and CBS News anchor, but also a devoted friend and volunteer for the Cystic Fibrosis Foundation.
Hello, I'm Scott Pelley. As many of you may know, I've been an active supporter of the cystic fibrosis community for nearly 10 years now. As the anchor and managing editor of the CBS Evening News and as a correspondent for 60 Minutes, I've had the opportunity to report on news that has a direct impact on people all across the United States and around the world. And I can tell you that on the day that I reported the FDA approval of Kaleido, it was a personal highlight for me and one that I know had an extraordinary impact on all of you gathered here. I've had the privilege to get to know many CF patients and families personally, and I understand what announcements like Kaleido mean to them. While we all know that Kaleido works for only a small percentage of CF patients, we also know that the science behind the drug is paving the way for new therapies for all patients. I want to thank all of you attending this year's North America CF meeting for your dedication and persistence over the years to change the course of this disease. I hope that each of you in the audience, whether a patient, a family member, a researcher, physician, volunteer, or other caregiver, all know the value of your commitment and understand how appreciated your work is by the Cystic Fibrosis Foundation. I look forward to reporting more positive announcements about new therapies for CF in the future. In the meantime, please keep up the great work. Have an exciting and productive meeting, and thank you for allowing me to play a small role in this wonderful community.
And now it's my distinct pleasure to introduce someone who knows this disease from top to bottom, someone who works hard in the clinic, someone who helps identify low-hanging fruit and collaborates with many of you in this room to bring new treatments to all of us impacted by cystic fibrosis. Please welcome my friend, our Executive Vice President for Medical Affairs, Preston Campbell.
So Cam, thank you for that really inspiring welcome. And I speak for everybody when I say we're thankful that Will's doing well. But I think we missed an opportunity with Scott Pelley's video.
Yeah.
Don't you think that he was congratulating them?
Absolutely.
Don't you think we should have them clap for themselves?
I think so.
Let's do it. And now I guess I better get to work. You know, I tried to get Mickey Mouse to do this welcome, and it didn't work out. And the reason it didn't work out is that Leslie Hazel, who's in charge of infection control at the CF Foundation, had a fit because she wasn't sure what type of contagion a mouse would bring into this hall. So that was nixed, and you're unfortunately stuck with me. But it's my pleasure, on behalf of everyone at the Cystic Fibrosis Foundation, to also welcome you to this year's North American CF Conference. And we wish you much success. We wish you much success as you gather together in the workshops and the symposia and the breakout sessions, as you learn and share with each other, and then finally as you inspire each other. As you inspire each other to go back and find creative ways to advance the science underlying CF disease, as you translate that science into new therapies and move us even closer to a cure, and you do that faster than we would have done without this meeting. Now, so we thank you, but you are the ones that are making that possible, and we're glad you're here. Now, at this point, some of you may be wondering, where's Bob? Because he's usually up here by this point, and you haven't seen him. And there's a reason for that. I mean, when I mention Bob, of course, I mean Bob Bell, the president and CEO of the CF Foundation. He's on the front row, but he's on the front row because he's moving a little bit slower recently because of an injury during the summer. What happened, you may wonder? Well, he was in a winner-take-all wiffle ball contest with his 11-year-old grandson. And in a desperate, and let me underline desperate, attempt to win in the last inning, Bob tried for an inside-the-park home run. And he was doing well until he made it to third base. And when he reached third base, his quadricep tore completely off of his knee. All right, you can do better than that. I want to hear a bigger, okay, so let me, whoa. And when he made it to third base, he completely tore his quadricep off of his knee. Yeah, that's good. That's good. So, yep, that's pretty painful. And we're actually just glad that he's here. And so I hope that when you see him, you'll wish him well. And I'll warn you that he's still very mad that he actually lost that game. But even though he's going a little slower walking around the halls here, he couldn't be going faster in his pursuit for a cure for cystic fibrosis. And never have I seen anyone under such difficult circumstances make so much progress in what he does every day to bring a cure forward for CF. So Bob, we thank you, and we look forward to good health next year. And you know, one of the things that helps us accelerate the science is this meeting, of course, and we're all looking forward to this week. And I want to recognize our co-chairs, Kim Reno and J.P. Clancy, and that's your cue for you all to stand up. And what we're going to do, so we put white marks on the floor for them to stand. It's taken them 3 minutes to figure out. I really do want to thank JP and Kim because they and the program committee that's listed here have worked very hard, as is always the case, to make sure that when you go home this year, you will say, once again, this was the best year we've ever had. And great things will happen. The next thing I'd like to do is thank our sponsors, because they are our partners. They do a lot to make this meeting better. So please stop by the exhibition hall and visit their booth, say hello, learn from them, teach them we would appreciate your doing that. There's one group here that I want to go over now, and that's this group that's a patient access group that we're calling We're Here For You Now. It's also the Patient Assistance Program. It's actually booth 200. And we all know that managing CF can be a challenge and many times overwhelming. But the Foundation is committed to helping people with CF get access to care and treatment that they need to live longer, healthier lives. So the Foundation has created more resources for patients and providers alike to help navigate all these obstacles that stand in the way of patients receiving the care that they deserve. This effort at the Foundation is led by a great group, Mary Dwight and the public policy team, who do unbelievable work, and will soon be joined by Dan Klein, who's going to come down from CF Services. So it's really an amazing work that they do. So be sure that you visit booth 200 in the exhibition hall and go over the resources that are available for you to look at there and see what's available that will save you a lot of time in the clinic and meet the very dynamic access team. So lastly, and speaking of dynamic teams, I have the pleasure of working with some really fantastic people at the Cystic Fibrosis Foundation, and Chris Penland, Dr. Penland, is one of those folks. He came to the CF Foundation soon after me, approximately 14 years ago, and I hate to think of how many questions regarding the science I've asked him. And the one thing that I appreciate about Chris, not as much as his knowledge and how he's moved the science forward and how he works with the consortia and all of our research programs and our drug discovery efforts, but below that, but not far below that, with all these questions that I've asked him, he's never once looked me in the face and said, "Preston, that's the dumbest question I've ever heard." So Chris, I thank you for that. And more important is that Chris works with these companies that are unraveling CFTR biology and bringing new therapies. So he was the perfect person to work with our two plenary speakers today, and he's going to introduce them now. So Chris.
So thanks, Preston, for that very kind introduction. It's a pleasure for me to introduce this afternoon's speakers. However, as I begin, I thought I'd take a few moments to recognize the unseen faces that contributed to this afternoon's presentation. We'll hear first from Steve Rowe about clinical efforts to bring CFTR modulators to persons with CF. These efforts rely not only on the hard work of physicians, nurses, research coordinators that are in the audience today, and the patients and families who are so giving of their time for the conduct of clinical trials, but also on less celebrated activities, such as translating protocols and packaging labels from English into other languages, synthesizing the building blocks of chemicals for their later combination into the final products, meeting customs regulations, reaching legal agreements with each trial site, allowing them to participate in these trials. Without everyone's contribution, then the clinical evaluation of CFTR modulators in the 12 different countries that have examined them so far would not have been possible. After Steve, we'll hear from Bill Skatch as he shares with us efforts to unravel the mysteries of CFTR biosynthesis and the multifactorial effects of the absence of phenylalanine at position 508. While Bill's lab has certainly contributed much of what we know today about CFTR, his presentation will also include insights from 12 other laboratories across the Northern Hemisphere. So I hope that you appreciate that it's going to take more than a village to raise a plenary. And now to the science of this afternoon's plenary. Stephen Rowe from the University of Alabama at Birmingham is a med-peds trained pulmonologist that first became interested in CF while serving as a camp counselor for children with special needs. His research is focused upon ion transport properties of respiratory epithelia, and the functional consequences of that ion transport. Steve will be followed by Bill Skatch. Bill's a Harvard-trained internist that specializes in oncology, and his research efforts are focused upon protein biogenesis, specifically beginning at the beginning, when the nascent protein is being synthesized and coming off the ribosome. I'd now like to welcome Steve to the stage.
Thank you,
Man, you're going to be great.
Well, thank you, Chris, for that kind introduction. I can't say that I'm very excited to be here among you and share this moment, a moment that has been, that we've been able to witness considerable progress in the care of CF patients. And I hope to share with you a vision for the future, a vision towards reversing the basic defect in CF. Well, it's been a remarkable few years. In the last 5 years, CFTR has been validated as a therapeutic target, leading to the approval of the first drug that addresses the basic defect. And new therapeutic approaches are poised to address the challenge of rescuing CFTR caused by many more common CFTR mutations, including F508del. And based on these and other advances, we are on the verge of the next generation of CF therapeutics that promise to change the face of the disease. But we can feel proud that we stand on a firm foundation as we look towards the next period of advances, when we can examine the remarkable progress quantified in this year's report of the CF Registry that shows for the last 25 years we've made a steady and consistent improvement in the median survival of patients with CF. That's matched not only by the improvement in number of years, but also the quality of life, and is due in large part by those of you in the room and the advances that have been made in the care of the individual CF patient and quality improvement initiatives that have driven those advances forward. But it's also in part because of new therapies that have come to fruition for the care of CF patients, in part driven by the CF Therapeutics pipeline, which tracks progress as CF treatments range from research and development towards availability of the patients as they move from the left side of the figure to the right side of the figure. And what you can see is that this therapeutics development pipeline is as robust as ever, filling a number of therapeutic areas, all of which have representatives that are now available to CF patients, including nutritional therapies, anti-infectives to combat the chronic infection, anti-inflammatory therapies, and mucus-altering therapies and agents that restore the airway surface liquid that are the mainstay of the daily maintenance of CF patients. But it's this top category, agents that modulate CFTR, that we're going to spend the rest of the talk today discussing, a topic that has increased in both number and width in the number of therapies that are progressing across the pipeline. Well, it's from a strong foundation of our understanding of the pathogenesis of CF that have enabled these advances in various therapeutic areas. And in this dominant model, it begins with an abnormal CFTR gene defect that results in an abnormal CFTR protein, resulting in a defective ion transport environment on the surface of our cells, which ultimately results in airway surface liquid depletion and delayed mucociliary clearance. That begins a cycle of destruction that begins with mucus obstruction in the smallest airways, resulting in chronic infection, inflammation, and scarring, causing bronchiectasis to ensue, and ultimately end-stage lung disease. And while there are considerable advances in our understanding of the pathophysiology of CF, even in the last year, which have aided our understanding of the roles of airway mucins on the airway surface, or the role of CFTR in transporting bicarbonate and regulating the pH environment, which has considerable impact on the mucosal defenses. One thing that we can say for certain is that by modulating CFTR itself can affect the beginning of this cascade and make considerable difference in the way patients feel, function, and survive. And to understand this a bit further, I'm going to take you through a video that we prepared to help you imagine what CFTR's role is in the cell. Here as I start this video, you'll see the ribosome doing its job, translating the gene into a full-length protein as it folds rapidly within the membranes of the inside of our cells. And then we'll see that CFTR progress through the cell, ultimately processing and reaching its active site at the cell surface, where it will then function as a tightly regulated gate channel that operates by channel gating, which opens and closes and allows the flow of chloride and bicarbonate to the surface. So let's start that video. Here again, we see the ribosome doing its job, translating the protein, allowing the insertion into the membrane. And then as those CFTRs accumulate, they're regulated into vesicles that then transport and traverse the cell to reach their active site at the cell surface. And once there, they insert, spread out, and do their job, which is to gate, as we'll see here, which is a gating motion that causes the channel pore to open, and a twisting-like motion allows chloride to flow. And the consequences of that are now able to be visualized in real time with new technologies, in this case with a laser imaging technology that allows us to visualize our cells in cross-section. And here you can see airway cells grown from primary human airway cell donors that have been proved to be an enormously useful model, first developed and popularized by Scott Randell and colleagues at the University of North Carolina at Chapel Hill, and used by many investigators throughout the world to unravel the nature of the CF defect. And here you can see the cilia beating very rapidly to transport the mucus that sits on the top of the cells across the screen from left to right. Whereas in the CF cells from a CF patient essentially don't have that function. They're depleted with airway surface liquid, and you can see the mucociliary transport is essentially static, with an end result of encouraging the chronic infection to ensue. Well, to begin to think about interrupting these basic processes, we have to have an excellent understanding of the various molecular defects that can cause CF. And in a model first popularized by Mike Welsh and colleagues, we can break CFTR mutations up into various groups. In this case, mutation groups we call classes. And it includes class 1 CFTR mutations, which result in nonsense alleles. The so-called X mutations that result in a foreshortened CFTR in which the mRNA is unstable and very little CFTR is produced to the cell surface. And one in which can be approached by a process called translational read-through, we'll discuss in the later part of the talk. It also includes class 2 mutations, or F5, which includes the most common CFTR mutation, F508del, where that CFTR protein is recognized as misfolded at an early stage in the processing, and ultimately resulting in the protein being degraded prematurely in the proteasome before ever reaching its active site at the cell surface. And then another group of mutations, these mutations that are found at the cell surface and can be grouped based on the specific category of their defect, including class 3 mutations, which are like a gate that is locked shut, or unable to cause that twisting motion that we saw and transport chloride and bicarbonate. Or other mutations at the surface like class 4 alleles, which are like a straw that's too small for your drink, or a pipe that's partially clogged, and unable to transfer as much chloride and bicarbonate as expected. Well, let's use another video to help demonstrate where we are today, which is that with the development and approval of an agent that can rescue gating mutations such as the G551D CFTR mutation. In this video, we'll see a CFTR that's where it's supposed to be, at the cell surface, but unlike normal CFTRs, are unable to gate until a molecule such as ivacaftor, a potentiator of CFTR, binds that channel, allowing gating to ensue and chloride transport to function. Again, here you see the channel locked shut until a molecule enables the gating, allowing chloride transport to flow. And we know now, based on the results that were shared at this meeting last year, that when this can occur with a small molecule that patients can take in the form of Kalydeco or ivacaftor, that we can witness really unprecedentedly large, and quick, and sustained improvements in lung function that lasted for the duration of this study, and were the principal reason that led the FDA to, and now the European Unions, to approve this drug for the treatment of CF. And in addition, there was a considerable improvement in the sweat chloride abnormality. In 50 years of CF research, we had not been able to make a dent in the sweat chloride abnormality until now. And now, with treatment with ivacaftor in G551D patients, the sweat chloride comes to a mean value that's actually below the diagnostic threshold for CF, showing that we've accomplished the goal of effectively modulating CFTR. But this trial is more than simply the results that have allowed the approval of this drug for a small number of people, but a roadmap for success that we can use as we start to think ahead on how we might apply the lessons to address more CFTR mutations and enable the treatment of more CF patients with effective therapies. And in this map that we've drawn that was adapted from work by Michael Wilshansky and colleagues, we can map CFTR function on the x-axis here. And this can be measured by a technique called nasal potential difference, or it can be drawn from the value of CFTR function derived from airway cells from similar patients. And on the y-axis, map sweat chloride. And what we can see is we can map our patients, those of individuals with the most severe form of CF, have very high sweat chlorides, typically 105 is a typical mean value, with little or no CFTR function. On the other end of the spectrum, patients without CFTR mutations who are healthy have essentially 100% CFTR activity and very low sweat chlorides. And this curve is populated by intermediate stages, including patients with a more mild form of CF, a CF that's characterized by pancreatic sufficiency, or other conditions such as CFTR-related disorders. And if we were to map on those results, the results of a previous phase 2 testing of ivacaftor, I think it's illustrative of where we need to be, using this again as a roadmap for success for how much modulation of CFTR is needed, how much CFTR function is needed to result in clinical benefit of our patients. And we can draw some general guidelines given that the approved dose of ivacaftor for G551D, 150 milligrams, is shown here in this blue circle. And we now know for sure that those patients have had pronounced improvements in lung function, while those patients that received lower doses had lesser extent, but still statistically significant improvements in lung function, providing, again, a map for how much CFTR function will be enough and what to target in the research laboratory. Well, as a community, we've never been one to rest on the laurels of success. And we, based on funding provided by the CF Foundation, we've been able to conduct a study called the G551D Observational Study, or the GOAL study, which is, in really an unprecedented effort, tried to catalog and characterize patients as they witnessed a change in the standard of care. As patients were enrolled before and then after, and watched after the approval of ivacaftor, to examine how those patients behaved in a real-world environment, and also collect measurements in the core study, shown on the left side of the screen, of a robust database of clinical outcome and biomarkers, including specimens that are now stored away safely for future research, including serum, urine, and plasma that will drive, and sputum, that will drive many years of research to come to help understand exactly what is happening in the clinic with effective CFTR modulation, and to help us drive forward for the next era of agents. In addition, we've been able to conduct 4 specific additional sub-studies among particular groups of these patients, including studies of mucociliary clearance led by Scott Donaldson, and measurements of intestinal pH measured by led by Drusi Borowitz and Daniel Gaffon, measurements of sweat rate led by Tanya Ganska, and measures of the sputum inflammation and microbiome led by Scott Sagal. And One thing that certainly does us credit as a group is the projected and actual enrollments that were experienced through the TDN trial. And despite the very much of excitement that resulted from the early approval of ivacaftor, which in many cases would have thrown a serious wrench in any trial that's trying to enroll patients at the time of approval, our community rose above those challenges, enrolling over a much higher number of patients than the original projection shown in green. And you can see it also started early and had a rate of enrollment that was essentially twice what was initially projected. Again, reflecting the dedication of the clinical researchers in the room, as well as our CF patients to help us learn as much as possible with this opportunity. And while it's too soon to share the final results, we've had some initial findings from the study that I'm pleased to be able to share with you at this point. In terms of lung function, or the absolute change in FEV1, we know that at week 4, with the 128 patients that have been able to be analyzed to date, there was a substantial improvement in lung function that, when compared with the results of the phase 3 study, despite this being more of a real-world environment, compares very similarly, showing us that indeed we are on the right track with CFTR modulation. In addition, there was, again, a pronounced improvement in the sweat chloride that was matched within a half milliequivalent of the results of the phase 3 testing in the clinic. And finally, while many of us were surprised to see the pronounced improvement in weight gain with ivacaftor, certainly pleasantly surprised, we've also been able to witness a similar weight gain in patients that have enrolled in the GOAL study, and again, matching very similarly to what was experienced in the phase 3 trial, and giving us confidence that the effort taken to run such a study will result in a robust amount of clinical and biospecimen data that can be used to drive future science. And we have the results of one of the sub-studies to be able to be shared with you today. Drew Borowitz at tomorrow's plenary will also share the results of the pH pill. But what we've seen in terms of mucociliary clearance, and these results analyzed again by Scott Donaldson, is a pronounced and unprecedentedly large improvement in the mucociliary clearance. Again, showing that targeting the basic defect, altering CFTR, and ultimately the pathogenesis cascade that follows can make a considerable improvement on something that we've all known is a cornerstone of the disease process. And while the rescue of G551D CFTR by ivacaftor is certainly a remarkable advance for those 4% of individuals that have been affected by its approval, it's also a clear reminder of the challenge before us and the challenge ahead. And I want to share with you now that the initial steps for addressing this challenge to bring CFTR modulators to a greater number of CF patients is already in progress. Today it was announced that younger patients with CF and the G551D mutation can start enrolling in a clinical study in multiple sites across the US and in Europe, enrolling patients 2 to 5 with the G551D CFTR mutation. Further, a study is already in progress that will expand the group of patients beyond the gating mutation G551D to a number of other gating mutations in which we know from laboratory studies that ivacaftor is extremely active. And we hope, even with conservative estimates, using the CF registry and the specific enrollment criteria for such a trial and the age cutoffs that we would expect, that even with these conservative estimates, that will expand the number of patients that are available to treat with effective CFTR modulators. And now I'm going to focus on another group of these surface mutations where it's quite reasonable that we could expect a considerable advance in treatment with CFTR modulators. And that is these class 4 mutations. Mutations, again, like a pipe that's partially clogged, are able to gate actively, but unable to transport as much chloride as they should because of that clogged pipe. And so now we'll take a look at a video that shows how ivacaftor therapy or other CFTR potentiators could be used to overcome this deficit. We'll see a channel that's moving very scant amounts of chloride despite gating normally, and then like a foot stepping on the accelerator is accelerated by an augmented gating caused by a potentiator. Again, here we see the channel functioning very poorly to move less chloride. But when gating is essentially doubled at the twice normal rate, this scant amount of chloride transport is overcome. Well, we now know that a trial to address this question in a similar way that G551D was used as a representative example of those individuals with class 3 mutations, patients with a particular conductance allele called R117H will be used as an example for a group of patients with conductance mutations. And in a relatively straightforward trial design that is already enrolling patients, patients will be randomized to receive either placebo or ivacaftor, the dose that's been proven to be effective for patients with G551D. And ultimately, if successful, this phase 3 trial design would allow increased availability of ivacaftor or CFTR modulators for a greater number of patients. Again, beginning to reach, with conservative estimates, about 7% of the CF population in the registry. And further, while a genotypic approach, going mutation by mutation, has certainly been a productive one and crucial to our initial approach to address CFTR modulation, it's now becoming clear that a clinical approach may also be warranted. And this is because CFTR potentiators can augment the activity of a variety of partially active CFTR forms. And therefore, ivacaftor will be tested in individuals with pancreatic insufficiency, regardless of CFTR genotype. So instead of marching through each of individual mutation or each individual class of mutations, patients can therefore be grouped by their clinical status, their clinical phenotype, pancreatic sufficiency, to reach a wide variety of CFTR mutations. And we now know that a trial based in the University of Colorado in Denver is already enrolling patients that will use such approach in an innovative N-of-1 design where each patient will serve as their own control before and after drug therapy. And we can expect that additional studies will emerge that will try to broaden this group further into more patients with pancreatic insufficiency. And if successful, we could expect this number of patients that could be addressed with a CFTR modulator to expand even further. This is some of the preclinical data suggests that this approach is warranted. These are a cell culture model that have had various CFTR mutations inserted into the cells, and then the activity of CFTR measured based on the y-axis of the curve. And you can see there's a great variety of CFTR activity that's observed from various different CFTR mutations, with those on the left side demonstrating little or no CFTR activity, and is generally associated with some of the most severe form of the disease. While mutations that are generally on the right side of the curve exhibit considerable, in some cases, residual CFTR function. And this is why we believe that many patients that are on the right side of the curve are also the genotypes that are associated with pancreatic sufficiency, because partial CFTR activity is enough to confer a more mild clinical phenotype. And we also know that the addition of ivacaftor to those mutations generally results in a consistent result, and that is that CFTR function is about doubled depending on the specific mutation when treated in these cell culture models. And when we map on this, that guideline that we've discussed before, that a 30% level of CFTR function should be enough to make a considerable advance in CF therapeutics, we can see that a great number of these mutations we could expect to offer benefit. Now I'm going to turn my attention, and your attention I hope, to the treatment of nonsense mutations by translational read-through. Again, these so-called X mutations that result in a foreshortened CFTR and also signal the mRNA as unstable and targeting it for premature degradation. So to help you think about this, again, we prepared another video. Here we're going to look further with a deeper zoom lens inside the cell to the ribosome actually translating the message RNA that encodes our genetic code into a full-length protein. We'll see the protein come off the ribosome and fold, but instead of completing its job, this ribosome will encounter a premature termination codon, a premature X codon, or a stop codon. And instead of completing its job, the ribosome will fall off, and and signaling the mRNA for premature degradation. So let's take a look at that. Again, here's the ribosome doing its job, translating the protein, but reaching, as shown in red, a stop codon. And the ribosome then falls off, is unable to complete its job. The mRNA is signaled for premature degradation, and of only a foreshortened dysfunctional CFTR results, and in scant amounts. Well, this can be approached through a genetic repair strategy that we've called translational read-through. We'll take a look at a video that shows this process. This is where an agent such as an aminoglycoside or other small molecules like PTC124 or atalorin can bind the ribosome, causing the ribosome to ignore that premature termination codon. And instead of falling off prematurely, the premature termination codon is read through. A full-length protein ensues. And in addition, because the CFTR protein is made in this first or pioneer round of translation, the mRNA is thought to be stabilized, allowing additional translation to occur even further. Here, again, we see the translation occurring, but instead of the ribosome falling off, in the setting of this small molecule that bound the ribosome, translation can continue, resulting in a full-length protein. And if we zoom out, we'd see that many ribosomes are doing the same thing, translating additional protein from this stabilized mRNA transcript. And if successful, again, because premature termination codons are relatively common, these X mutations are relatively common in CF, we could see that another 10% of patients could be reached by a modulation of CFTR. Well, these are results presented by Mike Constant at a symposia earlier today that shows one of the important and first shots on goal in a phase 3 study with PTC124 or atalorin for patients with premature termination codons in a global initiative study. And what was observed was that patients that received atalorin had a 2.5% decrement in their lung function measured by the relative change in FEV1 compared to individuals that received placebo where that was more severe, a 5.5% decrement over the end of the 1-year period, resulting in a treatment effect that was 3%. And all these changes were not statistically significant, and therefore the study did not reach its primary endpoint. We can continue to glean information from this study. Here are the results of one of the pre-planned sub-analyses of this study that compared patients that did not receive chronic inhaled antibiotics like Toby or Caistin or Colistin throughout the duration of the study in comparison to those patients that did. And what you can see is that those patients that were not taking chronic inhaled antibiotics, that there was a statistically significant difference in the lung function at the end of the study, of 0.2% for those treated with atalorin versus negative 6.9% for those that were treated with placebo, a treatment effect that was statistically significant, and indicates that if the patient one other important basis of this important sub-analysis is the fact that both before this study was conducted and in confirmatory studies after, we now know that aminoglycosides actually interrupt the process of atalorin-induced translational read-through, which could be the reason why this subset of patients on the left without inhaled antibiotics experienced a treatment benefit over the course of the study. And while, again, these results were not what we would hope that would lead to the immediate approval of this approach, we know from our other knowledge towards modulating CFTR that we're getting smarter and better at detecting agents that can be active and developing strategies to further those to the clinic. Here are results from David Bedwell and a colleague Timur Basov at the Technion Institute that have used chemical engineering approach to go back to aminoglycosides, or in this case, gentamicin, and then structurally engineer those molecules to augment read-through and leave behind its areas of the molecule that cause its toxicity or its antimicrobial activity. And what we can see is by using this approach that new derivative compounds like NB124 shown in orange can result in statistically significant improvements in CFTR activity using these primary human airway cells we've discussed before. You can also see that the level of activity that's seen is approaching 12%, which is beginning to be into the range that we'd expect to make clinical improvements. In addition, we also know that using a theme of experiments that we'll return to in the second part of this talk, that agents such as ivacaftor or VX-770 can be used to augment the rescue that's been seen in this setting, with essentially the CFTR activity being essentially doubled when these cells are co-treated with both their translational read-through agent and an agent to step on the accelerator and cause the gating to accelerate. Well, now I'm going to turn my attention to the F508 del CFTR mutation and approaches to correct its processing, an area that has plagued many of you in the room as we've thought about addressing this important challenge, which needs to be overcome to develop CFTR modulators for the greatest number of CF patients. Well, the F508 del CFTR mutation exhibits multiple defects that are important to consider as we can think about ways to address them. It has impaired cellular processing due to improper protein folding, resulting in premature degradation, and is commonly thought of as the principal defect that results in little or no CFTR at the surface of the cells. The small amounts that do escape this process that are delivered to the cell membrane also exhibit defective gating. Further, the mutation exhibits poor membrane half-life and increased cellular turnover. All challenges that would need to be addressed if F508 CFTR is going to be effectively addressed. Well, I'll show you, again, a video that will help you imagine the problem with the F508 del CFTR mutation. Here we'll see, again, CFTR being produced and inserted into the membrane, but relatively quickly you can see that the protein is misfolded. Some of the areas of the domains called the nucleotide binding domains are misfolded and larger than usual and don't take their final structure. This signals the cell to recognize these misfolded proteins as they darken or turn black, and which affects the efficiency of processing, where then little or no CFTR protein with the F508 del mutation reaches its active site at the cell surface. And the little that's there is, of course, misfolded and is unable to function normally. So again, here we see the CFTR protein undergoing its translation, but that nucleotide binding domain 1 is misfolded, and you can see that was a bigger, larger globular molecule than it should be. And these CFTRs that are being produced are dark in color because they're being recognized by the cell, and they're dropping out of the membrane prematurely, and they're certainly not efficiently processed. Where scant or few CFTR molecules then reach the cell surface. And if we were to take a closer look at those few CFTRs that do escape, those nucleotide binding domains are misfolded and essentially not transporting chloride or bicarbonate with any significant degree. Well, what would an era of CFTR modulation look like within the cell? This video will show that, where a two-drug therapeutic approach will be used. First, a CFTR corrector like VX-809 binds CFTR during the folding process, stabilizing it, resulting in a protein that looks more normal. In this case, it's colored yellow instead of the darker color that we've seen before. And some 15% of channels that do go through this process, as we know from preclinical data with this compound, do process then through the cell membrane effectively, reaching the site of the cell surface. And then we'll see the action of the second drug, in this case ivacaftor, binding this corrected CFTR to step on the accelerator and further augment gating so that more normal chloride transport can be experienced. Here again we'll see the ribosome doing its action of translation with a drug like VX-809 binding during the folding process, allowing a more stable protein to occur. And you can see that some of these yellow or normal CFTR proteins accumulating and then migrating to the cell surface, although perhaps certainly not in the normal number, but in sufficient normal number that when they reach the cell surface, a drug like a CFTR potentiator, ivacaftor, can be used to further augment what residual chloride transport is experienced. And therefore, again, resulting in a level of bicarbonate and chloride transport at the airway surface enough to make a difference for our patients. Well, we know from preclinical data that's been shown at this meeting and in years past that this is indeed possible in the laboratory. Here you can see the results with these primary human airway cells that show that with VX-809 alone, CFTR function can be partially restored, but when ivacaftor is used in combination, that effect essentially doubles, and achieving a level of over 30%, or approximately 30%, that is sufficient to confer what we think would be clinical improvement for our patients based on our previous experience. And in this phase 2 study, led and presented by Mike Boyle earlier today, we now have the results of cohort 2 of the VX-809 ivacaftor combination study. Well, this study was designed in part from the results of cohort 1 that were presented about this time last year by Mike, which showed that with the combination of ivacaftor and VX-809, that we could see improvements in sweat chloride when used in combination, and also established that a higher dose of ivacaftor would be needed to maximize the effect in patients that are already taking VX-809. So this resulted in a study design that's shown here, a cohort 2 of this same clinical trial, that looked at very first at a monotherapy period that was 28 days in duration, followed by a combination treatment period that was an additional 28 days, for a total of 56 days of clinical research study for these patients that were randomized to receive these treatments. You can also see that the level of VX-809 used in the monotherapy component of the arm tested some doses that we haven't seen before, up to 600 milligrams daily of VX-809 that was then added with ivacaftor at the 250 milligram dose twice daily. The study also included patients that were randomized to receive placebo throughout the duration of the study, and a group of patients who were heterozygous that received the highest dose of VX-809 in combination with ivacaftor. And now we'll walk through the results of this study. This shows the absolute change in FEV1, a measure of lung function that we all think about on a regular basis with our patients when they come to see us in clinic. And we'll see first the level of lung function change from the beginning of the study during the monotherapy component of the study, followed by the combination period where patients were taking both VX-809 and ivacaftor. In the first 28 days of those patients that received placebo, you can really see no statistically significant difference in lung function at that point in the study. With an additional 28 days of receiving placebo, there was actually a small decrement, about 3.3% difference in FEV1 compared to the start of the study, as we sometimes observe in phase 2 trials of this type of design. In patients that were assigned to receive either the 200 milligram dose or the 400 milligram dose of VX-809 at the first 28 days, again showed no significant difference from those patients that received placebo or from where they stood at the beginning of the study. But when ivacaftor was co-administered, we began to see a trend towards improvement in lung function. So at the end of the study, those patients received in those two groups were slightly improved in terms of their lung function compared to the start of the study. But again, changes that were not statistically significant. But if we examine the highest dose of VX-809 studied, we see results that are a bit different. Again, with the first part of the 28-day period, if anything, there was a little bit of a decrement in lung function that was seen at this part of the study. But then when ivacaftor was co-administered, we can see that the trajectory of that curve was quite a bit different, ultimately resulting in, compared to that patient, the average patient's lung function at the beginning of the study, a 3.4% improvement in FEV1 over the course of that period, a change that was statistically significant both for the individual subjects and also compared to those patients that were assigned to receive a placebo, with approximately 6.7% treatment effect between those groups. Here's another way to examine these data that break down the results in a more simple bar graph that shows the change either in yellow with the first 28-day period or the change within the second 28-day period shown in green. So again, in orange is the monotherapy period and in green is the combination period. And you can see towards the right end of this graph, are patients that were assigned the highest dose of VX-809, the 600 milligram dose in combination with ivacaftor, where you can see a considerable improvement in lung function during that period, achieving a bit over 6% change in FEV1, which compares clearly distinctly from those individuals that received placebo. Another way to look at these data is to look at the response on an individual basis. This is a plot of each individual patient, where each bar represents a single patient throughout the study. We're first examining here the results after the monotherapy period and the change in lung function during that period. In yellow are patients that receive placebo, and in blue are patients that receive the highest dose of VX-809, the 600 milligram dose. And what you can see is the number of patients that had an improvement in lung function is really essentially matched with the number of patients that had a decrement in lung function over the course of that 28-day period. And you can see from the shape of those curves that the number of yellow and blue lines, the shape formed by the yellow and blue lines are essentially identical, with no difference in those treatment groups. In comparison, looking at the change over the course of the second 28-day period with the combination treatment, you can see those differences in those curves begin to emerge. In blue are patients that received the VX-809 and ivacaftor in combination. And now you can see well more than half of the patients had an improvement in their lung function before the beginning of the study, compared to the smaller number of patients that had a decrement, of course, over the course of that 28-day period. And you can see the shape of this curve is quite a bit different than those that are shown in yellow, who are assigned to receive placebo. And further, if we use cutoffs that we often use in clinic to grade success, we can see that approximately 55% of patients had a 5% improvement in FEV1 over the course of that 28-day period that were assigned to receive active drug, and 25% of patients had a 10% improvement or better, showing that certainly in a great number of patients that the combination therapy was effective in terms of lung function. Well, based on these results, Vertex plans to initiate a phase 3 clinical trial program to evaluate VX-809 in combination with ivacaftor in F508 homozygous CF patients, which will take us, hopefully, if successful, to a next stage of CFTR modulation for a greater number of individuals. And the results could enable, again, the treatment of over half the CF population, based on the fact that about half of CF patients have 2 copies of the F508 mutation. Further studies will be needed to assess the effect of combination therapy in F508 patients who have only 1 copy of the CFTR mutation, which I haven't had time to show you, which did not result in statistically significant changes, and will be studied in future studies with higher doses of the regimen. And finally, I'll just point out that in parallel, there are other corrector programs, including VX-661, which is currently being tested as an alternative CFTR corrector with some favorable pharmacologic properties that make it a potentially better suited agent for combinations of single or multiple drugs in combination with ivacaftor. Well, you might be wondering, as a clinician, how are you going to decide what type of CFTR modulator would you use for each individual patient? And we know now that based on work presented last year by Patrick Sanze and Gary Cutting in the CFTR2 program, which is already available to you as clinicians as a tool to judge the phenotype of your patients, will ultimately also be used to help guide therapy, with specific guidelines on individual CFTR mutations being available to help guide treatment decisions based on the available data of CFTR modulation. So I hope I've been able to impart a vision for the future, how we've gone from discovery to proof of concept to clinical approval and wide use in a select group of CF patients, and how that studies are now already underway that could bring ivacaftor to treat a variety of individuals with these responsive CFTR mutations. And the next efforts will evaluate CFTR modulators in individuals with the most common CFTR mutations, including patients with the F508 del CFTR mutation. And I'll also point out that success has brought additional interest in the approach, We've now witnessed a great expansion of the number of academic and commercial laboratories that are investigating the correction of CFTR, and we will soon see the start of a clinical program by N30 as a CFTR corrector, followed by other discovery programs that are very active, including at Pfizer and Genzyme, among others. And our hope is that with an improved understanding of CFTR folding and processing, additional advances towards the correction of CFTR are imminent. And we'll be hearing about some of those details from my colleague Bill Skatch in the second part of the talk. And again, what I've hoped to impart is a vision for the future, how we're marching through patients with CF to try and develop CFTR modulators for hopefully all patients with CF ultimately. And this slide is to remind me that we're certainly not talking about bubbles on a diagram, but real patients with CF. And not just any patients, our family members, and our loved ones. So with that, I'm going to hand it over to Bill.
So thank you, Steve. It's truly an honor to be here today and to be able to present to you some of the data which has come out just over the last few years about how the F508del defect changes CFTR function and how our understanding of that defect is changing the way that we think we can now treat CF patients. I'd like to begin by thanking a lot of people that have sent me data, that have given advice, and that have really been involved in detailed discussions about this whole process, and in particular, two consortia groups which the Foundation has put together, the CFTR Folding Consortia and the CFTR Structural Consortium, both of which contain about 10 different investigators from many countries and different parts of the world that come together on a regular basis and hash out these details in late-night hotel rooms, sometimes late-night living rooms, and really trying to figure out what does the data tell us, what does the data not tell us, and where do we need to go? So what I'm going to do is take you behind the scenes a little bit to things that are a little less out in the open, that are underlying the new discoveries and the new drugs which are being developed. So what Steve talked about, and I'm going to review a little bit about what he said to start with, is that we now have modulators that can partially restore the F508del CFTR protein and get it to the surface. 5 years ago, this was just completely unthinkable, and now they're here. The problem is they don't work very well. We still don't have the level of correction that we'd like to have that will really have a big effect in patients' lives. So the next challenge is to really develop new correctors and new corrector combinations that will allow us to push this forward for more patients and for better outcomes. And what's really exciting right now is that these new discoveries in just the last year or two have changed the way we're thinking about this problem and have finally identified what these problems are and are now pointing the way towards the future. So I'm going to start with a piece of data that was published 22 years ago. This was from Seng Chang and Alan Smith at Genzyme. It's what got me into the CF field. I think it's what got many of my colleagues into the CF field. And there's two problems with this data. The first problem is that if you're taking care of CF patients, if you have loved ones with CF or family members with CF, it really doesn't mean very much. It looks like a couple of blobs. The second problem is, sorry Seng, but it's not a very good quality gel. What you have are kind of these very vague, indistinct, kind of dark spots. But what it told the scientists at the time, and it really set the entire stage for what we're now doing in CF, is that the mutant protein is different from the wild-type protein, and that the wild-type protein contains a lot of sugar, and therefore is larger, and the mutant protein has fewer sugars, and it's smaller. So to a scientist, this set up an entire process of thinking. This is a rendition of the cell and how CFTR moves through the cell. You can see from the blue lines that it follows these trajectories. It starts in the center, or what we call the cytosol. It moves to the endoplasmic reticulum. It's there in the endoplasmic reticulum that the protein is made, and it's folded, and it gets packaged into these little vesicles that Steve showed in his animation. It moves out of the ER and then goes through an organelle called a Golgi. It buds again off the Golgi, goes to the plasma membrane, and then it recycles around the plasma membrane until it ultimately gets degraded. Now, the important thing about Seng's data was that the sugars are put on in the Golgi. And that told us right off the bat that there's a problem in getting the protein from the ER to the Golgi. And that there's a defect here that was due to a misfolded protein. And as a result, that misfolded protein was targeted to degradation. And that caused people for the last 20 years to try to figure out, what is this defect? What is it about F508del CFTR that makes it stuck, not get out of the ER? We now know it's a bit more complicated. There's also problems with the plasma membrane with gating, as Steve talked about. There's problems with stability, both in terms of biological stability, that it's not as stable, it's degraded also from the surface, and functional stability. When it's at the surface, F508del is very sensitive to temperature and it rapidly inactivates. So just moving it to the surface is not enough. One needs to get it to the surface, keep it at the surface, and keep it active at the surface. So what I'm going to talk about today is really this issue. What is the folding defect? This has been driving labs all around the world for 2 decades. And I'm really excited to say that we finally think we know what the answer is. So the first problem of trying to solve this for patients was to say, can we find drugs which will help CFTR move out of the ER? And this was an enormous effort by the foundation that started with a large number of industrial and academic labs that basically use functionally based high-throughput screens. Take drugs, throw them on cells, and ask, does chloride current move? And these were very mechanistically naive. At the time, we really didn't understand what the problem was with CFTR. We didn't understand how the drugs might work. But what really amazed me and a lot of my colleagues was that they were incredibly successful. Every program came up with small molecules of different types, sizes, and shapes. And all of these small molecules helped CFTR get to where it needed to go. And this just shows a panel of compounds that the Foundation has provided to investigators free of charge around the world to try to understand how they work and what the real problems are. It became pretty clear in those studies, when these compounds were studied in different labs and we discussed what the results were, a new term started creeping into our vocabulary. It was the term of the ceiling, the corrector ceiling. It turns out that to get about 20% correction or 10% correction of the delta F mutation was pretty easy. This shows results from Phil Thomas's lab, where he looked at all 17, actually 18 now correctors, and was measuring current in an epithelial cell layer. And you can see that the wild type current is about 40 to 50, and these currents are around 5 to 10. All of the molecules that had activity were very, very ineffective. And as one might expect, when you looked at this processing, this addition of sugars to get to the mature band C form, you can see that while some of these correctors had an effect in generating more band C, none of them gave nearly as much band C, the mature form, as what you would see in the wild type protein. So this really was a difficult problem to overcome. Why were they so inefficient? Why didn't they work? And then a study came out from Martin Mency, who was at Epics at the time, I believe, and he said, well, let's combine these correctors. Let's take 2 different molecules. Neither have worked very well, and this shows now an Ussing chamber assay where you're looking at current, and as you go up, you see more current, and these are the curves for each corrector alone. When you combine the correctors, suddenly you see much, much more current. Okay? This was the first indication to us that the ceiling could be overcome. And it turns out now these types of experiments have been repeated around the world in many different laboratories, and I'm just going to show you a few examples. This is a study by Jeff Brodsky and Eric Sorscher looking at an analog of the Vertex 809 compound, which is called C18, and a molecule that actually blocks that degradation process. By itself, blocking degradation doesn't really do very much. But when you combine that with a molecule that helps the folding process, you now get a much greater effect. Similar results from Bob Bridges, showing that these correctors alone have very little effect, but when you add them together, you now see this additive effect in green and synergy effect in this hatched color. Results from Bill Balch looking at a different type of corrector. This is a HDAC inhibitor that actually is a histone deacetylase inhibitor and changes the way the genes are turned on in the cell and changes the environment of folding. And he combined very low levels of this HDAC inhibitor with very low levels of Vertex 809, which alone gave almost no response. And when combined, gave 50% of wild-type response in a functional assay. So what this told us was that our original model was not quite right. We had originally thought that there was this singular checkpoint that was keeping the protein from getting out of the ER, and if we could just find the magic bullet that would get it out of the ER, our problems would be solved. We now look at the problem in a slightly different way. It appears that there are multiple checkpoints, multiple places where this particular protein can get hung up. And if you overcome one checkpoint, you then get stuck at the next one. But if you overcome 2 or 3 checkpoints, you can actually be incredibly effective at moving the protein through the cell. So this really reestablished the kinds of things that we were trying to do. And I've drawn here several X's because it turns out that in the folding process itself, there are several checkpoints that I'm going to be talking about next. Now, when I first started talking to Preston about putting this talk together, I said, I want to show molten globule and talk about protein folding. There was this long pause, and Preston said, okay, Bill, remember your audience. So for the next few minutes, I'm going to talk about biophysics and tell you why biophysics is really very important in understanding CF. And the good news, I'm not a biophysicist, so I don't really know much about what I'm talking about, so I can't get too complicated. If we think about protein folding, what does it mean? We always talk about CFTR folding. It's misfolded. It's misfolded. It can't get out of the ER. What does that really mean? Well, protein folding occurs when a long string of amino acids starts coming together. And it does this in a very kind of haphazard and semi-directed way by flipping around in conformational space. And you can see here that this is a peptide which is now twisting, finding its partners, bending together, and ultimately coming into a compact state. You can think of this as sort of a string of spaghetti. And when it's folded, you can now see that it has structure. The spaghetti is twisted in a very precise way. There are loops, and there are linear segments. And I want to leave you with 2 messages here. Folded proteins have 2 characteristics which are really key for CF. They have structure, and they have flexibility. Certain parts of the protein you can see are very flexible, and they're bendable, they breathe. Other parts of the protein are more rigid, they're locked in place. Okay? So if you keep that in mind as we go through this CFTR problem, I think it will start to make a little more sense. And it took us, as investigators, many years to really appreciate these kinds of differences. Now let's try to apply this to CFTR. Well, CFTR is what I would call a molecular jigsaw puzzle. What I showed you was a very simple piece of protein, a very simple little domain that folds together. CFTR has many different pieces. It has transmembrane domains that span the lipid bilayer. It has these long extensions, and you can see how they're twisted into these helices that project into the cytosol. At the base of these, it has 2 nucleotide binding domains, which are both globular. And each of these domains has to fold in a manner that I just showed you. And then all the domains have to come together to make the final fit. And it's like puzzle pieces interlocking with each other. If you don't have the right puzzle shape, you can't get the pieces to come together. Okay? So a number of experiments over the years have now led us to a model, and this is a little higher resolution model of what Steve was presenting earlier. We know that the earliest events of folding take place as CFTR is targeted to the membrane. And our group showed that this really starts when transmembrane segments start to insert into this channel, this hole in the bilayer. Okay? These come off the ribosome in a linear fashion, insert and make a bundle that then moves into the lipid bilayer. The next thing is MBD2 folds, or MBD1 folds, comes off the ribosome. The regulatory domain comes off the ribosome. The second transmembrane domain is synthesized and inserted into the membrane. And then the second NBD comes off the ribosome. This is a very linear process. In cells, it takes about 7 to 8 minutes to make a single CFTR molecule at the speed with which proteins are synthesized. Once it's synthesized, then, we have these 2 nucleotide binding domains, and you've got these projections coming off the cytosol. And there's this crossover event where part of the second transmembrane domain interacts with part of the first transmembrane domain, and these red loops contact MBD2, and the purple loops contact MBD1. And when it all fits together, you end up with a functional channel that can leave the ER and go to the surface. Now, it would be great if it was this simple, but it turns out in cells, the environment of the cell has a lot of things that are helping proteins fold, and these are called chaperone proteins. So while this whole process is coming together, chaperones are binding CFTR, releasing from CFTR, rebinding CFTR, and changing the way the protein folds, changing the character of the way the protein folds. And this shows some of them coming on in a pictorial method, or a pictorial description, where they bind, they help the protein domains fold, they then release when the domains are folded. Different domains fold at different speeds, at different rates, and all the chaperones then, at the very end, will come off and the protein will be properly folded. And this is to illustrate the fact that in cells, the types of chaperones that are present are very important. The environment in a human airway cell is not the same as an environment in a muscle cell or a fibroblast, a skin fibroblast. The chaperone content of the cell is actually important in trying to get CFTR to fold properly. So how does F508del affect this process? I think early on, people would have thought it probably changes the fold. It probably doesn't get to the right folded state. But some really Herculean efforts by structural genomics that were supported by the foundation told us that wasn't the case. This is the crystal structure showing that spaghetti diagram of normal MBD1, and this is the crystal structure of F508del MBD1. And it doesn't take much to look at these and say they're pretty darn similar. And in fact, you have to look really hard to find any difference at all. Here's phenylalanine 508, right at that one spot, and there's a little loop here which is slightly different in the F508del molecule. So if this is the only structural difference in what F508del is doing to this domain, then how does it have such a huge effect on the protein in the ER, and why does it have such a huge effect in patients? Well, protein folding, as I said, is this linear process. Our group has been trying to understand how proteins fold while they come off the ribosome, and I'm just going to show you one piece of data. This is a very difficult thing to look at because there's lots of proteins involved in this process. But we know that the folding of MBD1 is fairly inefficient. And if you put F508del in NBD1, it's even more inefficient, or less efficient. So what we've been trying to do is measure the folding intermediates, asking at what point in the process does the protein start to fold. And we've identified that the N-terminus, the starting point of the domain folds first. Then a second folding event occurs when this alpha subdomain folds. That's where F508del is. And a third folding event is actually very important in incorporating this beta sheet core, these strands in the very center of the protein. And then the protein is finally folded. It turns out that this step is extraordinarily difficult and requires the biosynthetic machinery. We don't know much about this process yet. It's just in its infancy, and we're only starting to learn how this translation process is affecting the protein. What we do know is that you can take the protein that is folded, and you can study its properties in the test tube. And that's really given us tremendous insight into understanding what F508del is doing. So this is what is typically done. You take the folded protein, you grow it up in bacteria or some sort of cell, you purify it, throw away all the unfolded stuff, all the crud which doesn't fold properly, and then you unfold it. You can do this with heat, you can do this with chemicals, and you turn it into an unfolded state. Think about it like melting an ice cube. Here you have a state that's fairly structured, and here you have a state that's fairly liquid. Okay? And this is data from Christy Briette and John Hunt through the Structural Consortium that we're looking at the amount of heat that it takes to melt MBD1. And they showed that if you have wild-type MBD1, it takes more heat and a higher temperature to melt than if you have delta F508 MBD1. Which means that we're not dealing with a different structure. We're dealing with different flexibility. We're dealing with a more open structure. Like in the first video, where certain regions of the protein are more mobile, F508 deletion seems to make part of MBD1 more mobile. And that mobility is characterized by weaker interactions and less energy that holds the domain together. Why is this important? Well, it's important because if you can stabilize MBD1, you can get it out of the ER. And there are a couple of different ways to stabilize human MBD1 in CFTR. One way, and probably the most effective way, is to delete a piece of MBD1 called a regulatory insertion. This is an intrinsically unstructured, flexible region that is flopping in the breeze and kind of tacked onto MBD1 and CFTR. It's very unique to CFTR. We don't know what it does functionally because you can remove it and the protein still works. But we do know that if you take this off, MBD1 becomes more rigid. It becomes tighter folded. And this is shown by, again, Christy Briette's data, where she took a delta regulatory insertion, delta RI construct, and shifted the melting temperature back to wild type. And Jack Reardon's group showed that if you delete the RI and you express CFTR in cells, you make band C, you get more sugars, you process to the Golgi, and CFTR goes to the surface, and it functions. So this gave us a big clue that part of the problem is that you have a domain which is too unstable. Not that it's misfolded per se, but that it breathes more, it's more flexible. Another way to stabilize the MBD1 is to put in prolines. Prolines are kind of like rigid amino acids. They decrease the ability of the protein to breathe and move. And Jack Reardon looked at a couple of different animal models of CFTR and found that certain animals like chicken and I think sheep weren't as sensitive to the F508del mutation as human. And they had a lot of prolines in them. So he put the prolines in human MBD1, and he found that when he did this with one additional mutation, he could get a lot of band C, a lot of maturation. And he could restore function. This shows now the function of the protein, and wild type, as you raise the temperature, gets more active, whereas F508del rapidly inactivates. When you put the prolines and this additional mutation on top of F508del, you now find that you get more active. It was a very curious observation because what he found was that if you make MBD1 too rigid, it doesn't function very well at low temperatures. So CFTR from humans is living right on the edge. It needs a degree of flexibility in order to be functional at the right temperatures. And that flexibility makes it very susceptible to the F508del mutation. Now, there are other ways to stabilize MBD1. There are solubilizing mutations that were identified mainly in mouse that were put into a lot of these constructs to make them for crystallography. There are suppressor mutations, which were actually identified almost 20 years ago now, and they've really lied dormant. They haven't really had much interest. But work from Gergely Lukasz's lab has shown that if you put these suppressor mutations into human CFTR, MBD1, with and without 508, this is with 508, you can shift the melting curve back to wild type. This is a slightly different assay than what Christy had used, and it uses a fluorescence-based model, but it's basically measuring how the protein unfolds. And you can make it more stable. And then what Gergely did was very clever. He basically quantified the stability based on the melting temperature and compared it to how much CFTR got to the surface. Now this is the melting temperature of just MBD1, and this is how much CFTR gets to the surface, and here's wild type. What this told us was that you don't get much MBD1 to the surface if you just, a CFTR to the surface, if you just stabilize MBD1. It gets a little better, but it doesn't get very good. It sort of hit a ceiling. And that told us there's another problem. That stability of MBD1 is important, but it's not the only problem. And the other issue that came up over the last couple years is this folding assembly defect, the jigsaw puzzle. These domains have to fit together just right. And F508 lives right at the junction, the top of this green MBD1 and the bottom of this blue loop coming down, which is the fourth intracellular loop, so it's called ICL4. This is what it looks like if you blow that up. Here's F508. This is the culprit that we've all been trying to figure out for the last 20 years. It sits right in this pocket. This is a model of CFTR, probably pretty close to what the protein looks like, but we're not entirely sure. Now, it doesn't sit there all by itself. It actually sits there surrounded by a bunch of other things, so it's in a pocket. And this particular residue fits into that pocket like a ball in a socket. When it's gone and deleted, it leaves a hole. And proteins don't like holes. So that weakens this interaction between these helices that extend into the cell and the MBD1s that bind to them. So two very clever experiments were done. The first by David Clark up in Toronto. He said, well, if this weakens the interaction, maybe I can strengthen it in a different way. He noticed that close to this residue was an arginine, which has a positive charge on it. And what he did was replace a residue with a negative charge. And since positive and negatives attract, this should increase the affinity for these two pieces of the protein. And sure enough, even in the presence of delta F508, he found that now he could get trafficking, just simply by adding this charge and making the connection between the domains slightly more strong. A different approach was used by Pat Thibodeau in Phil Thomas's lab. Pat didn't change the valine here and put a charge. What he did was he changed the arginine, got rid of the charge, and put a big bulky group called a tryptophan. Tryptophan looks a little bit like phenylalanine. And the reasoning was maybe if you put a big bulky group here, it'll go in and fill up the hole. And sure enough, when he put the bulky group on the wild type protein, there was no place for it to go and it caused lots of problems and you got less protein. But when he put the bulky group on F508 del, now he found trafficking in band C. So you can stabilize this domain interaction even in the presence of F508 del by using different types of mutations that bring the domain together and mimic what the protein is supposed to do on its own. This leads us to our current model of what happens to F508 del CFTR. So it starts pretty much the same as the previous animations. The transmembrane segments insert, MBD1 is made, chaperones bind, the R domain, the regulatory domain is made, chaperones bind, second set of transmembrane helices get inserted into the membrane, MBD2 comes along, gets synthesized, but MBD1 doesn't fold properly. It doesn't condense quite as tight as it ought to. MBD2, as a result, probably doesn't fold as properly. And the chaperones that were bound are replaced by other chaperones. And these chaperones now recruit small molecules called ubiquitin, and the ubiquitin serves as a signal for degradation. And a large protein complex called the proteasome comes up, and just like a child eating spaghetti, kind of sucks the protein out of the membrane, chews it out, and spits it out. That is the basic problem. And so because MBD1 doesn't fold, and because the domains don't come together, those two defects turn out to be the underlying problem that we've been searching for the last 20 years. Now, this would be interesting, but what makes it incredibly exciting are two papers that were published earlier this year by Gergely Lukács and Phil Thomas. And what they showed was that if you just fix MBD1 stability, this is what you get, a little bit of wild type. This is the total amount of protein, and this is the efficiency of folding of the MBD1. You just get a little bit of wild type CFTR over here. If you just fix the domain interface, you just get a little bit of wild type protein. You get a little bit of protein at the surface. But if you fix both, the interface and the stability problem, now you get 70 to 80% of protein at the surface compared to wild type. It is now possible for the first time to really turn the F508 del mutant protein into a wild type-like protein. And it's not just protein at the surface. This is a functional study where the function of these proteins were also very close to wild type. So this is incredibly exciting. It explains the ceiling problem. The ceiling problem is we were only hitting one of the defects. And the synergy gave us clues, because when you put in two different molecules, you can hit more than one defect. And when you start hitting both of these defects in multiple ways, you can now get to wild type levels. And that is now charting the course for the future, because now we know where to go. We know what to target, and we know what to fix. And the challenge is to figure out how to do it. So we can now go back and look at these correctors and try to figure out in a slightly more sophisticated manner what they're doing. This is, again, data from Phil Thomas's group, where he now looked at the correctors on the background of a stabilized MBD1 or a corrected interface. And you can see in the black hatched marks that the correctors themselves don't do very much. And in the presence of these mutations, some of them also don't do very much. But a couple of these really stand out. For example, corrector C3, which is a very early Vertex drug, has a huge effect, bringing the protein almost up to wild type if you stabilize MBD1. Corrector C18 or C16 has an effect on both of these stabilizing mutations. So if you look at the data in a slightly different way and just plot the different stabilizing mutations on the axes, and then how much CFTR you get, you kind of group these into correctors that don't really work very well at all with either of these. Correctors that seem to have a marked effect if the NBD1 is stabilized. And these correctors are likely working at that interface, bringing together this transmembrane domain and the nucleotide binding domain. And here you have correctors that complement both defects. These correctors probably act via yet another mechanism, either changing the chaperones, changing the protein folding environment, changing the trafficking process through the cell. These are acting at yet additional checkpoints. So of course the big question then is, what about VX809 and some of the correctors that are really very exciting? So it's now been looked at, and VX809 has a very interesting mechanism of action. If you look at C18, which is a VX809 analog, you can see that it doesn't really do very much if the domain-domain assembly is corrected. But it has a huge effect if you stabilize NBD1 with a simple suppression mutation, bringing it pretty much up to the wild-type protein levels. So this tells us that VX809 acts to correct the defect at the interface in some way. And very interestingly, work from Ineke Brakeman and Doug Sear, who will be discussing this process tomorrow at one of the symposia, have found that it doesn't work on NBD1. It seems to work on one of the transmembrane domains. It seems to act at the first transmembrane domain, membrane spanning domain 1. This is proteolysis data where Ineke looked at the fragments that were generated by a protease in the presence and absence of the VX809 compound, and found that it was transmembrane domain 1 fragments that changed, not NBD1 or transmembrane domain 2 or the R domain. She also found a very interesting finding that when you add the drug is very important. For VX809, the drug works best when it's added during the translation process, implying that the events that are occurring while the protein is being made are the target events for where 809 actually exerts its effect. So this really now also leads us forward in many different directions because, as you know, delta F508 is not the only trafficking mutant in CFTR. There are other trafficking mutants. This is from Juan Mendoza and Phil's lab, showing where they're located. Some of them are down in the nucleotide binding domains. Some of these trafficking mutants are in these helical extensions, and some of the trafficking mutants are in the transmembrane domains themselves. So Fred Van Goor kindly provided this slide, which shows how Vertex 809 acts on one of the transmembrane domain mutants way up in TMD1. It's way here. It's nowhere near delta F508. And what he showed was that if you grow these cells and measure chloride transport in the presence of VX809, you take a protein which is completely inactive, and you basically turn it on to wild type. This is 100% of wild type activity, and the mutation is E92K. And if you add VX770 or Kalydeco with 809, you actually exceed wild type activities. And that's compared to the G551D, which gets you to about 50% activity for VX770, and about 25 to 30% activity for the F508 del mutant. Truly remarkable. This compound seems to act in the first membrane spanning domain, and it seems to completely correct a very severe defect in that region. But another mutation, which is right next door, it's only 5 residues away, G85E, has no effect. So these are highly specific processes, and we need to know what it's doing, why it affects one mutation, and how different mutations have different processing problems. And this is where the field is headed. This is, again, work from Phil Thomas's group, which Linda Mullen did, and he looked now at 67 mutations which are in the CFTR2 database. And about half of these mutations turn out to be trafficking defects. So here's the amount of protein that you get for wild type, and anything below this line is trafficking defective CFTR. He then plotted these trafficking defects on a graph and said, let's look at what the NBD1 mutations do to NBD1 folding, and found classes of mutations. For example, some of the mutations affect NBD1 folding and drop the amount of total CFTR, like delta F508. Other mutations have no effect on NBD1 folding or the amount of CFTR, and these are likely gating mutations. There's a class right here which is really very interesting because they don't really affect NBD1 stability. What they do is they seem to affect interface interactions, and that needs to be tested further. And then there are mutations that probably affect chaperone binding and surface transport through the cell. So we can now start to look broader, both at how delta F is affecting the problem and how these other mutations relate to delta F, and tailoring therapy and finding out which correctors will work for which types of mutations. And this has really led to the next generation of screening, which was really instigated by a strategic initiative from the Foundation for Next Generation Discovery. There are a number of corporations involved: Vertex, Genzyme, Pfizer, Proteostasis, Reata, GlaxoSmithKline. Each of these is now incorporating this kind of basic knowledge, this basic understanding, into better, smarter ways to solve the problem and find compounds and find drugs. The challenges now are to design ways of looking for these. Looking for the NBD1 target. We really do not have good compounds yet that stabilize NBD1. We can do it with mutations, but it's very difficult to find compounds that do this. So we need better studies of biophysical protein analysis, cell-based studies looking at NBD1 stability, genetic complementation to screen for these specifically targeted correctors. Domain assembly. We don't have a good assay yet to really characterize this interface between the ICL4 and the NBD1. And that needs to be worked on, and there are a number of labs that are doing that. The genetic complementation experiments can be done as well. Restoring cellular homeostasis. Can we make the folding environment more conducive and help get what little F508 is made out of the ER better? And use that in combination with drugs which help the folding process. We're moving more into relevant systems, using human airway epithelia early on in the screening process, using assays that are very physiologically relevant, like the ability of airway to absorb and secrete liquid in vitro, inflammatory responses, and of course, a big goal is to increase the chemical space. We've barely begun to scratch the chemical space in the current screens or previous screens that have been done. This is just two examples of the kinds of studies which are being done in complementation with each other. So this is an assay developed by John Hunt, where he takes pure NBD1, puts a fluorescent probe on it, and then looks at how the fluorescence is quenched when NBD1 is aggregating. And he does another temperature assay, so it's, again, a melting and aggregation study. And this is F508del, this is wild type, and the idea now is to look for drugs which move the mutant to the wild type. He's put this into a high throughput assay that can now screen hundreds of thousands of compounds. A similar assay was developed by Gergely Lukács, where he does an unfolding assay with this fluorescence-based approach, where again, F508del melts lower temperature than wild type, and now this is also in a high throughput format that can be used to screen for drugs which stabilize the domain directly. This will target a very specific defect. And with these very in vitro kind of biochemical assays, we can complement them with newer and better screening assays in human airway cells. This is a system that was developed by Bob Bridges and Will Van Driesch at the Rosalind Franklin University, where you grow cells, and now you can do high throughput or moderate throughput screening on primary airway epithelial cells from CF patients. This is a major advantage from previous studies which were using Ussing chambers, which were much more tedious and were very limited in the number of compounds that they could be used for. Finally, I'd just like to mention that the CF Foundation has established a laboratory called the CFFT Lab outside of Boston. It was just established this year, and the entire purpose of this lab is to develop these new novel assays, bring them to the forefront of the screening process, work at the interface between academic labs, the structural and folding consortiums, and pharmaceutical companies that want to implement these assays using these biochemical assays and primary airway cells. So I'm going to stop where Steve left off, and that is with many of the current therapies, we're at about 50 to 60% potential therapy for CF patients. If we now extend this to heterozygous delta F508 CFTR, we're at about 90%, and we think we now have the directions to go to actually get delta F to work as good as wild type. And if we incorporate many of these other trafficking defects, we're now very close to 100% of patients that will eventually be covered in the near future. And we're doing this in a smarter way than we've done in the past. We're more focused on the specific defects that are present, and we're much more targeted in the way we're approaching this problem, using a wider range of new assays that have grown directly from the basic science research that are now affecting patients. And I'd just like to say that having worked on this process for about 20 years, it still amazes me When I think of what we do in our lab and what other people do in their labs, where we take minute amount of protein and we're measuring these very arcane biophysical properties, that what we actually find has relevance for the patients you're treating. And it's just incredibly exciting and incredibly, rewarding to see these fruits now coming to real drugs and real compounds and real screens that are going to be hitting the clinic in the near future. Thank you very much.